yes, including the heart, yes. We had a question here.
I just want to ask, like, the proteinuria condition, is it because only for diabetes, or is there any other condition that leads to proteinuria?
Definitely, there are more conditions which lead to proteinuria. Okay, the main risk factors are always high blood pressure. Some people take indiscrete amount of pain medications like Advil, Aleve, ibuprofen. Okay, people think that those are anti-inflammatory medications. Okay, but those actually can cause a lot of damage to your internal organs. GI system, kidneys bear the brunt of it. Okay, and this is sometimes just people are not aware of the side effects of these medications. People take it for sprain or arthritis, and they think that, oh yeah, my pain is gone. Okay, but again, that is leading to a lot of internal organ damage. Okay, so yeah, those are other conditions. There are very rare conditions sometimes where you have like blood cancers or other inflammatory disorders of the kidney, which are beyond the purview of today's talk. But those can lead to protein in the urine too. Yes.
Thanks.
What is the safe doses of Aleve or Advil if necessary? If we have
No
to
safe
take
dosage.
No safe.
There's no safe
Not
dosage.
recommended.
Advil or Aleve or any of these NSAIDs, non-steroidal anti-inflammatory drugs, you need to take them only, say if you have a sprain, you take them for about 2 to 3 days, that's it. And that is under advisement of a physician, okay, number one. Number two, if you have to take any medication which is safe from the kidney standpoint and you have chronic pain, again, treat the cause of the pain, number one. And number two, Tylenol is a safe-ish medication, I would say, but again, under very much, I would make sure that I follow all the healthy lifestyle guidelines, while I do take that, yes.
We have two kidneys, right?
Yes, we do, yeah.
And people live with one kidney, right?
Yes, they do.
Suppose both the kidneys fail, is there any other ways to prevent the person dying or?
Yes, as we said, when you progress, from kidney disease standpoint, you have the modalities of dialysis, which helps people to live, okay, or they can have a kidney transplant. Yes.
My husband is taking Jardian and 4 metformin, and he lost all the weight. With the Jardian, does he lose all the protein because he lost all the muscles and water weight and all that?
So, there's a good question, by the way. Okay, Jardians actually will help you from not losing the protein in the urine. So it is anti-proteinuric in a way.
But how come he lost all the
So
weight?
So yeah, so with Jardians, what happens is, the medication will make you urinate out the excess glucose. Along with it, it takes the water out of the body. So your water weight is lost when you take Jardians. Okay,
But
so you're not
muscles?
losing muscle weight, with Jardians. Unless you're like not doing exercise at all, or you're on the bed all the time. Okay, which obviously is not the case. So, one more question then.
So, is it true for antacids also that you say painkillers are not good for you? So,
Correct.
Antacids also?
One category of antacids is a medication called as omeprazole or pantoprazole. Some of those, when taken for more than 4 years to 5 years at a time, have been shown to cause progression of kidney disease. You ideally should not be taking those for that much period, because when you read about them, the FDA approval for them was a total period of 3 months, 90 days. Okay, so people take them chronically, and this is again, a very common thing which I see in my clinic. People have been on them. Why do you take? Oh, I have acid reflux. Why don't you change the habits which are causing the acid reflux? Go to the base of the problem. So, yeah.
Are you saying continuously or are you saying there could be a...
Continuously. If you take it once in a while, it's fine.
So with that, we'll pause for now. We'll pause briefly. Dr. Dhananjay will be here with us. We're going to invite Dr. Ramanamurthy here to talk about another aspect of the diabetes, which is the eye disease. Thank you, Dr. Dhananjay.
How many of you are diabetic? How many of you have been diabetic for more than 10 years? How many of you have, who are diabetics have been getting dilated examinations of your eyes at least annually? So I'm a retina specialist. Don't ask me about cataract. Don't ask me about LASIK. Don't ask me about double vision. I'm kidding. People ask me, but I don't know if I tell you all the right answers. So I've been in practice for 30 years here in the community. So my specialty is retinal diseases and uveitis. So today's talk is about diabetes because it's obviously something that I see all the time. And if you're seeing me in the office, it's bad. You've done a bad job with your health. Bad. You're going to go blind. If you're seeing me, you're probably going blind or gone blind. Don't come and see me. Avoid me. That's the point of this talk. The best way to treat diabetic retinopathy is not get it. How do you get it? It's like making diamonds. You have to really work hard to get diabetic retinopathy. You know what you have to do? Don't go to your doctors, eat whatever you want, don't take your medicine regularly, and then get fat, don't exercise, don't do anything, you'll get it. If you're an Indian and you live in this country, you're going to get diabetic. I'm a case in point. I'm a case in point. All my fathers, everybody in my family that came to India from India, all are diabetics. All. My father-in-law, who just died a month ago, adult onset diabetic, skinny as a ray, 90 pounds, had silent coronary disease found incidentally 30 years ago, subsequently got multi-infarct dementia, all kinds of things related to diabetes and vascular disease. Okay? So bad news. The problem is we all are at risk because of our diets, lots of things. Our relative level of inactivity, the climates, all of these things play a role, I am sure, in us developing diabetes. But as far as retinopathy, you have to, in order to get retinopathy, you have to have diabetes for long enough and treat it badly enough to get bad disease in that particular organ. Okay? So the diabetes can affect the eye in multiple different ways. You can develop corneal changes. Cornea is the clear window of the eye. Lens, you can develop cataract more quickly. In the retina, this is the most important because retinal problems and also nervous system problems, and somebody was asking about neuropathy, but neuropathies can affect the eye too. You can get double vision because you can get cranial nerve paralysis and so forth as a result of diabetic microvascular disease. Diabetes is a disease of small blood vessels and large blood vessels, but for me as a retina specialist, it's a disease of small blood vessels. And what advantage I have is that I can look inside your eye with the special lenses after your eyes are dilated, and I can tell you how much damage you have based on, and then I can ask you questions like how long have you been diabetic, what is your latest A1C, what's historically been your A1C. Those kinds of things help me a lot in telling me how good or how bad the retina is going to look even before I look in your eye. So looking at the eye itself, just so that everybody knows what I'm talking about. Does everybody know where the retina is? The retina is the retina is the back of the eye. It's an extension. I consider it an extension of the brain. It is part of the central nervous system. I think of the eye wall as like a camera, right? You have a lens system, which is the cornea mainly, and the lens that fine focus the light that comes into the eye onto the surface of the retina. The retina is a nerve tissue. It's very complex. It has blood vessels in it, and small blood vessels that we can see, and we can see damage directly to those blood vessels from diabetes. So the problems with the nerve tissue is that it can't regenerate. If you damage the nerve tissue because of high blood sugars and changes that occur to the capillaries in the back of the eye as a result of diabetes, you can't reverse that. You cannot undo that damage. Once it gets to a certain point and you have vision loss from this damage, you can't recover from that vision loss. There's no magic there. We can't reinvent your eye. We can't do a retinal transplant. We can't do an eye transplant. So whatever you lose, most of the time you lose for good if it's as a result of this microvascular disease. And I'll show you some examples. But the center, when we look into the back of the eye, this is what I see. This is just the central 15% of your retina. This is the optic nerve, the cable that connects the eyeball to your brain. And this is what the retina looks like. These are the blood vessels in the retina, and if I pay close attention to the blood vessels, this is the center part of the retina where all your 20/20 vision takes place. That's called the macula. The macula is where we can see swelling in the macula, we can see loss of blood flow in the macula, we can see retinal detachments that involve the macula that I'll show you. So we see in diabetes, we see diabetic retinopathy occur in patients who have, based on their A1C levels, based on the duration of diabetes. You can see, and I think Dr. Menon probably already talked about this, but the prevalence of diabetes in the world is dramatically increasing. And it continues to grow significantly. And it's based on a number of factors. But the availability of processed foods and fast foods and lifestyle changes, all of these things are impacting populations globally. And we're seeing tremendous increases in diabetic retinopathy everywhere. So, you know, I'll tell you that there are two types of diabetics that I see in my office. Those who are type 1 diabetics who've had diabetes from a young age, who are insulin dependent. And those folks they typically don't have any retinopathy when they're diagnosed, but after 10 or 15 years, they will develop retinopathy. And if they do, most of the time they go directly into very severe retinopathy. And the disease process itself is very short-lived. It goes through a cycle of activity about 2 to 5 years, then it kind of burns out. So the goal here is to try to treat those folks, try to get them early, of course, prevent it from happening by keeping their blood sugars well controlled. And nowadays we have the ability to do continuous glucose monitors. We have pumps, insulin pumps that can actually keep the children regulated to prevent diabetic retinopathy from developing. The good news is, in my hands at least, in most of the insulin-dependent diabetics that we see, that we're able to monitor and treat, the outcomes can be good even if they develop severe retinopathy, because they're young. And so they have some resilience based on their age, and so we can recover vision. The toughest patients that I see are you guys, people who are in the audience who are older, who are type 2 diabetics. Because type 2 diabetics tend to have, in my opinion, very recalcitrant, very difficult to treat diabetic retinal disease. They tend to develop macular edema or swelling in the macula, which is very difficult to treat. They tend to develop, with long-standing, really poor controlled diabetics, they tend to develop really severe retinal complications like traction retinal detachments and things like that, that are very, very difficult surgical disease problems and very hard to manage. So again, we talked about history of diabetes being an important thing. There are other things too besides diabetes that play a role in diabetic retinopathy, and the other doctors already alluded to this. You have high blood pressure, you have poorly controlled cholesterol. All of these things will play a role in you developing the diabetic retinopathy and the severity of the diabetic retinopathy. Pregnancy is a specific case where diabetic retinopathy can change dramatically. So if you're a diabetic and you're pregnant and you have retinopathy, if it's already been diagnosed, that needs to be monitored very closely during your pregnancy, because you can become blind during pregnancy from progression of the retinopathy. So there are many trials that have shown that the best way to prevent diabetic retinopathy is glucose control. So if you have good control and keep your A1Cs low, well below 7, your likelihood, if you have lifetime control, your likelihood of developing diabetic retinopathy is significantly less. We know that based on insulin-dependent diabetics that were studied in this particular trial called the DCCT trial, but we also know that that can be extrapolated to people like ourselves who are adults who have diabetes. So glucose and glycemic control is really, really important. So we don't really know exactly all of the fine-tuning mechanisms of retinopathy, but we do know that what happens is the same thing that happens in the kidney. There are cells in the small capillaries that surround the capillaries called pericytes. In the kidney, they're called podocytes. Those cells basically die off as a result of, we think, because of the effects of glucose and inflammation. And as a result of that, the endothelial cells, the cells that line the inside of the capillary, balloon out, get damaged, and they leak. And the glomerulus in the kidney, as the doctor was telling you earlier, those kinds of things lead to eventually scarring of the glomerulus. The glomerulus doesn't function very well, and it results in all kinds of problems in the kidney. Same way in the eye, when these capillaries leak, the retina becomes thick and swollen. Later, what happens is the capillary actually completely dies and doesn't work at all. Then you don't have any blood flow to the retina. Then you get much more serious complications in the eye. So let me show you some changes that happen. I'll show you some better pictures, but this is kind of what the changes that occur. I don't want to get too technical because it's a little bit beyond the scope of all this, but these leaky blood vessels eventually cause the swelling in the center of the retina. The retina can look very abnormal. You can develop hemorrhages. You can develop areas of what we call exudates, which is cholesterol and lipids that leak out into the retina from the bloodstream as a result of leaky blood vessels. But when the blood vessels stop working, then you develop abnormal blood vessels in the eye. That's called proliferative diabetic retinopathy, and that results in hemorrhaging in the eye, severe vision loss, and retinal detachments. So we can actually, as retina specialists and ophthalmologists, we can grade the severity of the retinopathy and determine how closely we need to follow you and give you advice on what you need to do, just as these other doctors do. And also tell you that we need to follow you closely. By the time you get retinopathy, the cat's out of the bag, okay? So you need to be, once you are diagnosed with diabetic retinopathy, say you have this amount of diabetic retinopathy, you need to be checked more frequently than just once a year. Once a year is good as a screening tool before you get retinopathy or in the process, but after that, once you develop retinopathy, generally we're going to see you more frequently. I'm going to skip through all this, but I'll just show you some pictures. This is a picture of a patient who is a mild diabetic retinopathy. We use several test methods to try to determine the severity of retinopathy. We use something called the fluorescein angiogram, which is a special dye that we inject in the vein in your arm or hand, and we let the dye go through, and we use special filters to take pictures. And you can actually see these, remember I told you the capillaries, they balloon out? These are these ballooned out capillaries. Those are called microaneurysms. This is the back of somebody's left eye. This is the optic nerve. These are blood vessels in the retina, the big blood vessels. But these are small capillaries. So these little white spots are all damaged capillaries. You can't really see that very well when you look at somebody's eye in that picture, except I can see it when I look with my microscope and my special lenses in the office. Later on, you can develop more severe disease. You can have little hemorrhages in the retina. Again, these kinds of things may not affect your vision. You may not know you have anything going on. It's not, oh, I got blurry vision, I must have diabetic retinopathy. That's usually not the case. You can have very severe diabetic retinopathy, have 20/20 vision. I have hundreds of patients I can show you that have excellent, perfect vision, but they have horrible diabetic retinopathy. So that's why it's so important for you to have examinations regularly, dilated examination, where somebody physically looks at your retina at the back of the eye. Okay, so this is another picture where we see hemorrhages in the retina. This person has 20/20 vision. That white spot's called a cotton wool spot. And you can see there's the pictures here. As the diabetic retinopathy progresses and gets more severe, you can actually see beading of the retinal blood vessels. You can see, these are called microvascular abnormalities. You can see still those microaneurysms, all kinds of things that we use, the technical jargon that kind of describes the severity of the retinopathy. Let me show you this. And so this, as the severity progresses, we can start to see more hemorrhages in the retina. And then later what happens is that you can see all of this, so much hemorrhage in the back of the eye. This patient is starting to have some mild visual dysfunction, severe disease. And now as they progress further, you can see that in this entire area, all the capillaries are damaged. Let me go back a second and show you that picture. And this patient has pretty decent vision. He was like 20/30, 20/40 in both eyes. Both eyes look the same. But look at this. Look at this, how abnormal this dye test looks. So you can see the large blood vessels, right? But look at all the small branches that should be there. They're all missing. Everything is dark in here, right? All of these are damaged, lost capillaries. This is very advanced disease. You can't bring those back. They're gone forever. So if they did your peripheral vision test, you'd have big blind spots where those capillaries are lost. And that leads to much more severe disease. The next step from this is to develop from NPDR what we call proliferative disease. I'm sorry, I keep so then we get...
Let's say the growth factor has been affected.
I'll get to that in a second. You see So we'll see then the next step is you start to get abnormal blood vessel growth. And here on this slide, it's a little washed out. Abnormal blood vessels growing on the optic nerve. There are abnormal blood vessels growing here. Those are called neovascularization. That's proliferative diabetic retinopathy. That's very severe disease. Those patients, that patient had 20/20 vision. It has, a scale of 1 to 10. If somebody said, how severe is that? That's like a 6 or 7 in severity. Here's a patient that in later stages of that has started to develop scarring of those abnormal blood vessels and retinal detachment. Those become surgical diseases. They're really difficult to treat. We have lots of tools available to us to treat those things, but you can also see severe proliferative disease. You can see all these, there are more abnormal blood vessels than normal blood vessels in this eye. There's all these abnormal blood vessels growing from the optic nerve. You'll have to take my word for it because you're not retina specialists. This is a bad eye. And that patient had 20/40 vision. They're not going to stay there that long. So when patients come and see me, he said, my vision's fine. Why are you telling me all this bad news? I tell them, you're like the passenger who's in the 747 that's flying at 800 miles an hour, falling free fall, okay? And at 500 feet off the ground, your pilot dies, and you have to somebody else has to take over the flight. That's me in the driver's seat with your eyeball. So it's, and then when we start messing with something like this, right? What do you think is going to happen? We start doing treatments on these patients, they're going to get worse. So your treatment made me worse. No, you worked really hard to make this diamond for me for 25 years of not doing anything, and you came in like this. And this is, when, in retrospect, we can sit here and understand that. But when you are the patient in the chair, it's very difficult to sell that to a patient, right? So anyway, as a doctor, we face this all the time. I know the other doctors know all about this. They're chuckling.
I'm going to use that.
Yeah. So this, the treatment really is prevention. Take care of your blood sugars, take care of your blood pressure, take care of your cholesterol, and get your retinas checked. As soon as you're diagnosed with diabetes, you should have an annual checkup done by an ophthalmologist. Someone who dilates your eyes, takes a look at the back of the eyes on an annual basis. Once you develop retinopathy, then if you need treatment, the treatment options are going to be determined by your ophthalmologist. Okay? So many treatments are there. The treatment paradigm has changed a lot. 30 years ago when I started my practice, when I was in my fellowship, all we had was laser. But laser treatment has reduced the rate of blindness from diabetic retinopathy from 25–30% in the days of the 1950s and 1960s, now to less than 4%. The thing that's changed even more is the introduction of medications that we inject in the eye that prevent that inhibit a specific growth factor called vascular epithelial growth factor, but there are several other factors that we're looking at too. But what we call anti-VEGF or vascular endothelial growth factor agents, those agents have revolutionized how we treat diabetic retinopathy. We can actually, in non-proliferative disease, milder disease, we can reverse retinopathy by using these medications. So you can actually see reversal, and you basically are buying people time when you do that, but that requires monthly injections of medications for 2 years or more. It's a very big time commitment, and it's expensive, and there's risk involved with it too. But I have seen patients dramatically improve on these treatments, remarkable changes. So, and there are also other agents that we can inject in the eye. So laser we can do in the office. We still do some laser treatment. It's still there. And laser is a very important part of diabetic retinopathy treatment. It's not abandoned at all. So we use it in conjunction with this anti-VEGF therapy. We use in other diseases too, but in diabetes in particular. And here's a guy getting a shot in the eyeball. So you might get freaked out looking at that, but it's not as bad as it looks. And it's like we do, in our office, my practice does probably 300 to 500 injections a week. So we do a lot of injections a week, and most retina specialist practices are like that. We also can do surgery for very advanced disease. I don't know if the thing will play. This is kind of a slow video. I wanted to fast forward. This is me operating on a patient with very severe retinopathy. But I'll leave that going, and I'll kind of stop and maybe take some questions, and you can see what we do. Okay, does anybody have any questions specifically about the eye? Yeah.
Oh God.
There's fluid in our retina. There's a fluid. Can that be reversed by controlling the glucose? So there's a like, people having diabetic for 20 years, they end up developing fluids in the retina. So if they control glucose, can that be reversed automatically or can?
That's an excellent question. So, I tell people when I see them for the first time, and let's say that I look and in the macula, you're specifically referring to macular edema, which is fluid in the center of the retina and the macula. It's affecting their vision. In those, or it may not be. Maybe the vision is still pretty good. Regardless, when I see them for the first time, I'll ask them, what is your blood sugar control? What are your A1Cs? What have you been doing? If they tell me, I wasn't taking care of myself and 6 months ago I started Jardiance. In that situation, what I would probably say is, let's monitor this very carefully and see what happens as you get better glucose control. There are also some concerns. I'm sure that Dr. Meenan may have addressed this, but when you have people who are really, really poorly controlled and their A1Cs are 10 or 12, I had one lady who was 15 recently. When they get controlled suddenly and quickly, you can actually see if they had retinopathy to begin at that point and they suddenly get controlled, you can see a paradoxical worsening of the retinopathy early on. But that's not a bad thing necessarily. We monitor it, take care of what needs to be taken care of, but they still need to stay on the path of getting those sugars controlled. So long-term, glucose control, blood pressure control, cholesterol control, you have to have those things. Otherwise, we can win a battle, but we're not going to win the war.
One more question. So in this case, so if the doctor recommends anti-VEGF, but at the same time, the diabetic patients, like the wounds don't heal, so they are in a deadlock.
Yeah, so I think that one thing you have to keep in mind is how much of that anti-VEGF agent, he's a smart guy, he knows something about wound healing.
I'll ask you for my mom, sorry.
Yeah. So there is some effect. Some of the anti-VEGF medicines that we inject in the eye, small amounts are absorbed into the systemic circulation, into the body, and they can cause things that we don't want. So impaired wound healing may be one of them. This has not been well documented in our literature. But I think that there's such small amounts that are being given that you can't blame it necessarily on that. Because if a patient has impaired wound healing because he's diabetic, that's probably a much greater factor than what I'm doing to treat the eyeball that's affecting her wound healing. Does that make sense?
Yeah.
I mean, she has peripheral vascular disease probably, and she has significant reductions in blood flow to her extremities that are preventing the wound healing.
Yeah.
Yeah, so you have to weigh those kinds of things out. I think though the benefits for vision from treatment with anti-VEGF substantially is greater than the potential risk that you're not going to heal and all. So that's my take on this in most cases. Because if you're dealing with non-healing diabetic foot ulcers and things like that, you're dealing with people who have very, very advanced disease.
Thank you.
Yeah.
Bobby, one basic question. So for people who are diabetic for a long time, or people who are late in their like seniors or something like that, would you recommend doing this eye exam more frequently than just once a year?
If you do it once and there is no retinopathy, I think it is fine to be monitored on an annual basis. If there is evidence of diabetic retinopathy and the grading of the retinopathy makes a difference. If it's extremely mild or minimal, you can still be seen once a year. But if it's mild more than that, I will probably see those patients about every 6 months. So, but if you have no retinopathy, you're fine to be still seen once a year. But you should not ignore that. You remember that your vision can be very good with very advanced disease. By the time the vision gets affected, the cat's out of the bag. You're in big trouble.
I had a question in continuation to what he asked. So, is it doctor refers to you, or how it happens, or is it annual checkup and then they get to know how it happens?
What do you mean?
Right,
To get to me?
Yeah.
Well, if you're an ophthalmologist, most ophthalmologists feel fairly comfortable monitoring diabetic retinopathy. An ophthalmologist is an MD. An optometrist is an OD. There are very good optometrists, there are very good ophthalmologists. There are very bad ophthalmologists and very bad optometrists, okay? I don't think it really, in my mind, makes a whole lot of difference. But what you should do is that they should be dilating your pupils and looking in the back. And so if they see a problem in the back, generally, an ophthalmologist or optometrist is going to say, hey, this is beyond my ability to do, I don't want to do treatment, or they may feel comfortable doing injections, but they won't necessarily feel comfortable doing laser treatment, etc. So they may refer you then to me.
So the procedure is having a, I'm asking for my mom, she's in India, so just asking. So it's basically having an annual checkup, and then they see something, and then they refer to retinopathy where
a retinal specialist, yeah. So to see a retinal specialist, usually you will have to have retinopathy that is significant and it's causing vision loss or vision problems.
Thank you.
Yes, yes, sir.
Do you see retinopathy with long-term A1Cs of like 6.5?
You can. Again, it's a disease process where it's time, it's duration, and even so, if you have 30 years and A1Cs of 6.5 technically are still abnormal. So if you have 30 years of diabetes with A1Cs of 6.5, you potentially could. But the severity of the retinopathy, we know, based on the clinical trials that we've done for insulin-dependent diabetics and extrapolated to adult onset diabetics, tends to be less severe in patients who have A1Cs under 7. 7 tended to be the magic number in most of those clinical trials, and maybe you guys can correct me.
Is dilation is really must, because nowadays they just do some, they said we have advanced machine and no dilation.
Yeah, I know. So that's called replacement of your brain with a machine. So I don't believe in that. I'm sorry, I'm old and I can say bad things like that.
Yeah.
But there are a lot of young doctors who, the optometrists especially, and they will charge you for the pictures, right? Yeah. When you see me and I dilate your pupils, or you see an MD, an ophthalmologist, when you bill your insurance, they pay me $5 for the pictures and you pay $29 or something for your optometrist, okay? So it's a business game, okay? Bottom line. But let me tell you what it really means, is that, they generally those pictures on the flip side, and I was being very facetious, on the flip side is those pictures can be very helpful if you know what you're looking at, okay? So you have to have some training to look at how severe the retinopathy is. Sometimes you get a picture and it doesn't look that bad. But a guy like me will look at it and say, that's pretty severe retinopathy. That patient needs to be seen, okay? So that's why a physical examination is not there's no substitute for somebody looking at your eye and actually making a diagnosis as opposed to just doing pictures that you look fine, I'll call you with the results tomorrow or something. Does that make sense?
Yep. And just another quick question. Do you think, I'm not sure it's the right question for you, but do you think like diabetes or long-term diabetes can lead to glaucoma and affect your eyesight?
Yeah, no, this is an excellent question. So we do know patients who have diabetes are at greater risk for developing other vascular problems in the body, right? Similarly, glaucoma is a condition that we think has significant vascular causes. So if you have high blood pressure, if you're diabetic, or you have really bad cholesterol,